the growth of non-clinical careers has really been an attempt to bring physicians into many of the aspects of healthcare to help improve the delivery, improve the experience for the patient, improve quality, improve all aspects of that, and hopefully get us to a better, more efficient system.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management at the Naveen Jindal School of Management. Here at the University of Texas at Dallas, we bring together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare ecosystem. I'm Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management. Be sure to subscribe on Apple Podcasts, Spotify, or your favorite podcasting app to ensure you don't miss any of the future episodes. You can also join us online at businessofhealthcarepodcast.com. Today, we get a refresh on the dynamic changes that are underway and significantly impacting the role of physicians. We are welcoming back Dr. John Mehall to the Business of Healthcare podcast. John was featured 5 years ago in episode 43, entitled Filling Medical Staffing Gaps. At that time, he had performed over 5,000 cardiac surgeries and was running a staffing solutions company with locum tenens surgeons and managing an independent cardiothoracic surgical group in Colorado. No longer a surgeon, but a serial entrepreneur, physician leader, and investor, we're ready to learn more about a relatively new phenomenon of non-clinical careers for physicians. Welcome back to the Business of Healthcare podcast, John.
Thanks, Bob. It's really a pleasure to be here, and I certainly appreciated all that you've done with this podcast. It's been quite impressive.
Well, John, let's get on to the topic of non-clinical careers. What are the non-clinical careers for physicians?
Really, a non-clinical career is really a physician who's not directly providing patient care. And it's relatively a new phenomena. Probably 40, 50 years ago, there were very, very few physicians, if any, that were not treating patients. And now there's an explosion of opportunities for physicians to use their knowledge of medicine and healthcare delivery in ways other than direct patient care.
Wow, you think about that. We live in this changing world. We talk about the healthcare system a lot, and sometimes we refer to it as a kludge, a workaround or a quick and dirty solution that's clumsy, inelegant, inefficient. Sounds like healthcare sometimes. But along with that comes a tremendous amount of change also. So this is a new shift for physicians. Why are we talking about this shift, and why is it so important? Why is it noteworthy?
Well, I think what you just alluded to is the complexity of healthcare. If you think about, we didn't used to talk about healthcare systems and healthcare delivery and all the aspects of it, 50 years ago in the 70s or even the 80s maybe. And really over the last 30 or 40 years, the growth of healthcare has been explosive. It's almost 25% of our GDP now. And it's taken on so many different layers. And part of the problem, which you also mentioned, is its complexity and its clunkiness. And sometimes when you have folks who are really good software engineers, lawyers, administrators, or other things, and they maybe don't fully understand some of the nuances of what it is involved in caring for a patient or delivering that service, then sometimes the service comes off as clunky and disjointed. And I think the growth of non-clinical careers has really been an attempt to bring physicians into many of the aspects of healthcare to help improve the delivery, improve the experience for the patient, improve quality, improve all aspects of that, and hopefully get us to a better, more efficient system.
Well, that's a mouthful right there when you start talking about the dynamic changes. We talk about the changes all the time, trying to keep up with these things. So what are some of the driving forces of change that are creating these new opportunities for physicians?
Sure. I think just think about one of them being electronic health records and everything being digital now. I don't want to date myself, but I am old enough to remember when we did everything on paper charts and there were hard copy radiology images and you would go to one file room and hope that the x-ray that you wanted was there. And, all of that has migrated into a digital format. And, you've got really, really smart people who are doing this, but they don't necessarily understand how care is delivered, the way to sort and store images, things like that. And so that's one area where physicians have had instrumental roles in developing EHRs and developing PACS and radiology image storage systems and all these other things, because then they're the ones also using those systems to read and interpret the images, or to chart and document the care, to chart and document billing. And I think that's just one way in which the delivery of this service has become much more complex. It used to be the doctor could show up with a small bag of tools at your house and take care of you. As idealistic as that sounds, I don't think anybody actually wants to be cared for in that manner. And in order to leverage the amazing technology that we have to do diagnosis and to do treatment, and to even think about treating patients over with telehealth and telemedicine, where you're not even in the same location, all of that has really been driven by technology, and you need physicians and nurses and other healthcare providers to help make that transition from taking a software product into an efficient patient interaction tool. So that's just one. I mean, and along with that has come regulation and laws. You think about Affordable Care Act and some of those things, Transparency Act for hospitals. There's all these, as healthcare has grown into a bigger business, there's so much more regulation and, legal aspects to delivering the care as well.
Yeah, it seems like delivery is really becoming a whole lot more complex. The focus in the past has always been on patient care, and now you just can't be limited to that. There's much more to be concerned about. Like you mentioned, the documentation. Wow, the things that are doing that's not directly related to patient care. That could be an interesting thing. So we look at what's driving the whole transition here right now, really looking at the next dimension here. Why are the doctors looking at this? Why are they pursuing non-clinical careers? Are they pushing away? Are they pulling towards it? What's the story behind that?
Well, I think it's probably individual for each person. And the one thing I would reemphasize is that, we really do have a need for people who really deeply want to care for patients. And caring for patients, which I did for many years, is a really very intimate experience with you and that patient. And what makes it special also makes it not scalable. And so I think when people are wanting to do something else, they're usually being driven to that for two reasons. One is they have some dissatisfaction of the way that they're delivering care. And, we can talk about that, kind of separately. But obviously, as the care delivery has gotten more complex, the administrative burden has gotten more complex, the amount of non-clinical work that's being put on clinicians has gotten greater. The dissatisfaction of that and the physician and nursing and other healthcare provider communities has grown significantly. And so that can't be ignored. But I think a lot of people are also being drawn to these other careers because of the ability to combine, altruistic goals, which most physicians have, and science and other interests to have a bigger impact. And so, I have a very good friend who's an informaticist and was a primary care physician for years, and now is an expert on public health and informatics. And he truly feels that he is able to have a much bigger impact on more patients doing that than he ever would have been seeing patients one at a time in primary care practice. And so you can think a lot of different aspects to that, where people could develop pharmaceuticals and create a life-changing, life-saving medication that could impact thousands or even millions of patients. And so the appeal of doing something that is at scale and has a bigger impact, it scratches the itch that physicians have to make a difference, and it's making a difference for more people than maybe caring for one person individually.
Well, when you have a complex environment that doesn't let you do what you want to do, really perform at the top of your license, and you have things that start to erode on your personal time, You're sitting there saying, I don't have time to do the things I need to do. You may not have the autonomy to make decisions like you used to. I can see the negative things might be the motivation to move you in a different direction. On the opposite side of that, you talk about the positive side. What about the work-life balance? Is that something that's eroding away right now with physicians? Is that a concern? How you get organized?
Yeah, I mean, there's no doubt that's a big part of it. And, when I think about that, I kind of categorize it as autonomy in the sense of, physicians and providers still have clinical autonomy, by and large, but they really do not have organizational autonomy or the control over their work environment and how that is carried out at the same level that they used to. Very few physicians are in independent practice anymore, although there seems to be a swing back in that direction. And when you're a employee in a large, organization, you think, even United Healthcare is the largest employer of physicians in the United States. They employ nearly 100,000 physicians. So it's the proverbial turning a battleship in the ocean when you're in one of these giant health systems or hospitals or health plans or multidisciplinary things. And that's very difficult because the organizational structure does not allow a lot of individual control. I think there's also been impact on some of the decision-making autonomy of physicians, probably for the better, candidly, in the sense that we now have evidence-based medicine. We have clear evidence of what is the best thing to do for a large group of patients. And historically, you used to have a very nuanced individual physician care, and there was very much an art to it. And data and science have squeezed a lot of the art out of it. And now you have practice protocols and other things which are driving care. So I think all of those have diminished some of the autonomy of the physician role. There's also been a rise of advanced practice providers who are doing a lot of the things that physicians used to do, which really should help because then physicians should be more at top of scale. But as you alluded to as well, the growth of the administrative non-clinical burdens that are placed on clinicians, whether it's charting, coding, documentation, non-clinical duties, committees, things like that, that has exploded as well. And so all of those are making people spend less time in direct patient care. I read a study where the average hospitalist in the United States spends about 12% of their time actually caring for patients, and the balance doing paperwork and transfers and discharges and admissions and all the other things that are necessary to make the machine operate. And so that has had a big negative impact on people's desire to do direct patient care and remain in clinical work. And I think the pandemic simply exacerbated all of that. And post-pandemic, the CDC said we lost 2.9 million people left the healthcare workforce as a result of that. So there's probably some work that needs to be done to address how clinical care is delivered and to improve that. And the only thing I would say is I'm definitely empathetic to hospitals and other healthcare delivery systems in trying to do that, because if they're trying to take care of a lot of patients, the single most expensive component of that is labor. And, all those health systems and hospitals run on very tight margins. Very few people realize that the margin of running a hospital on average is about the same as a grocery store. And about a third of the hospitals in the United States run on negative margins and make up the difference through foundations and charitable donations. So they're trying very, very hard to get as much as they can out of all of that labor force because they just don't have a lot of resources to buy more labor to meet the need. So there is some imbalance between the need and the existing labor force, which also is driving people to look at alternative non-clinical careers.
Well, I know one big thing that motivates most people, no matter what profession they're in, is money, dollars. Let's explore the potential illusion of what it means to be a doctor. So I'm sitting here thinking, you go to school, the gestation period's about 10 or 12 years to get into practice. And then you take on this job. You probably have got school debt. You probably have a deprived life that you want to make up for, move forward in another direction. And so you're locked into this business of medicine, practicing medicine. Is it more financially rewarding? Is there a stalemate there in terms of earning capacity? Can you actually do better by starting a business and have more earning power by looking at these non-clinical careers? What are your thoughts on that, John? You've been through that before.
I'll give you a couple of thoughts on that. My first is you should really do what your heart is calling you to do. Don't do what you think you're going to make the most money at.
Okay.
Because what you're going to make the most money at is constantly changing, and there's a lot of luck involved in life. Certainly hard work and persistence matters, but follow your heart is my first comment. The second is I think there's a significant lack of financial literacy in the healthcare community. And a lot of the literature and knowledge that's out there in the financial world is not directly relevant or apropos to physicians. And so I'm actually working with a startup called AndWise to try and improve financial literacy in medical students and residents, because there's very big tipping point, as you said. You go 11 years on average to create a new physician in the United States. And when they finish their training, they go from, making whatever, I want to say $35,000 because that's what I made as a resident, but probably making, $40,000 or $50,000 as a trainee to making several times that or more. And when they do that, they're probably in their early 30s, and they recalibrate their lifestyle based on what societal and their spouses and families and friends' expectation of them is to be a quote doctor. And what they probably don't necessarily take into consideration is they're way behind the curve on savings for retirement. They've lost some of the time value of money because they're older entering the workforce. And the way our healthcare is paid for now is really based on what's called RVUs, or relative value units. And there's no differentiation between the compensation for an RVU done by somebody in their first month of practice versus someone with 25 years of experience. And so once they get out and start making money, their compensation level is likely to be very flat. And in some cases, in some specialties, it's actually gone down over time as reimbursement for that work has gone down. And so if you come out at 30, whatever, and you expect to, continue earning more progressively over time, and it ends up being flat, you haven't saved for retirement the way you probably should have. All of a sudden, maybe you have some children, maybe your spouse or significant other stops working and you lose that second income. You start saving for college, you need a bigger house, so on and so forth. Then you tend to get upside down very quickly. And I think that is a very critical transition point that not all physicians handle well. And the ones that don't handle it well then end up, in their mid 40s or their 50s. And it's almost impossible to decrease lifestyle in America. So then they're looking for additional revenue, and they're working extra jobs, or they're working more. And I think that's a trap that a lot of people have fallen into, and it definitely can create more burnout. And the last part of your question was about, can you make more money in a non-physician career? And the answer is probably it depends. I would say most non-clinical careers probably actually pay less, because the work product of physician work and patient care is relatively lucrative. So if you switch and you're doing remote chart reviews for insurance companies or legal work or other things like that, you probably are having a better work-life balance, but you may have diminished your earning potential. I think some of the exceptions to that could be very successful hospital administrators. And certainly if you go on to lead a health system or a large hospital, you could do as well or better. And there are people who have entrepreneurial pursuits and can create businesses that then have value. And there's people who go into research, and maybe you can, create a blockbuster medical device or, new pharmaceutical. But I would say those are the exceptions. And if you're switching from clinical medicine to non-clinical medicine to try and make more money, that you probably have the wrong motivation.
Yeah, I was thinking more along the lines of the entrepreneurial alley, finding ways to hit it big, to basically transition to a new opportunity.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
We talked about the financial aspect of it, which was really important. And you also mentioned that, do some self-reflection. Think about what makes you happy and what your situation is. But if we were to shift into a coaching mode, what kind of advice, what would you tell people to do if they wanted to pursue a non-clinical career? What would you advise them to do as a coach here, John?
Yeah, so I get that call quite often from friends, colleagues who are disillusioned, unhappy in their clinical career, and they want to do something else. And the first thing I really try and dig into is what you said, Bob, is self-reflection. Why do you want to do that? And I think for them to understand that is critical. And the overwhelming majority of people that call me and say they want to get out of clinical practice and do something else, they don't really know why they feel that way. They just know that they're unhappy. And if you don't know why you want to change or where you want to go, the odds that where you end up is going to be the correct answer for you is really a crapshoot, So if you know what port you're sailing to, you're likely to get there, but otherwise you're just adrift at sea. So I think that's the most critical thing. And it may be that they really like clinical work, they just don't like their current situation or the way it's being administered or their practice pattern or something like that. And that could be addressed by a change in their practice location or setup. But if they truly have a calling to go do something else, and the folks who I've seen make this transition successfully, they really have something they're running to, not something they're running from. And if you have something that you're excited to go do and you feel that you see a need that you want to go meet, whatever that is, then I think you're likely to be very successful in doing that. And so once people have identified something they're excited about doing, then I just encourage them to really dig into that, get as much knowledge as you can, talk to as many people as you can, network in that space, really understand what it is that you think you want to do. And, occasionally you might think you want to do it only to learn that you don't. But if you truly dig in and talk to a bunch of people, learn as much as you can, and you're really excited about it, then I think you're likely to be very successful in doing that.
Yeah, that might require more credentials, maybe different education, maybe. Obviously, you want to feel qualified. You don't want to be an imposter here. So you want to feel like you have the authority to venture into new areas like that.
I think that's right. Yeah. I would just expand upon that to say, when you're doing a lot of this exploration, you're probably doing it in addition to your current job. You're not going to quit work and go, go on sabbatical and do professional exploration of what you want to do. And whatever it is you decide to do, when you start that, you're really kind of back at the ladder in terms of expertise and experience. Now, you're bringing a very valuable and different perspective by virtue of your medical training and medical experience and healthcare delivery experience. And that will bring, new value to that endeavor. But you also probably don't have some of the skills, that someone who has already been trained in that has. And so if somebody's already been trained in that and they have specific financial skills, specific managerial skills, specific skills related to, medical legal work or whatever it may be, you're at the beginning of the ladder learning those skills, and you have to remember that. So you're right. So sometimes additional training is needed. And a lot of that exploration is kind of done in addition to your regular job. And I think that's obviously hard for people, because if you think you're overworked and you want to make a change, now you're actually adding work to figure out what the right change is going to be.
Yeah, that's good advice. The old rules of wing walking, those are the performing artists that were on airplane wings. And the rule was don't let go of one thing until you get a hold of something else. So
that's great advice.
Want to make that jump at that high level of risk.
That's right. And I would say too, like we mentioned a minute ago, Bob, is that a lot of these people are mid-career and they may have dependents and significant others or children or whatever that are relying upon them, especially if they're a single income for that household. So it is not risk-free. And these are, kind of weighty decisions to make.
Well, let's shift the topic here just a little bit. I think we're all aware. If not, maybe we can educate our audience to the degree this is happening, but there's a significant physician shortage. And there's a lot of factors that probably fit into that shortage taking place. And this transition we're talking about to non-clinical careers, I'm sure that has a factor as well. Give us some insights, if you would, on this physician shortage that we're facing today.
Yeah, I think the physician shortage is a real issue, and there are a lot of components to it. So, we in the United States have a system where we put people through medical school, and then they have to do some graduate medical education after that before they can independently care for patients. And what few people realize is, number one, it's a long process. We mentioned earlier, it takes about on average 11 years. And the other aspect is that we're actually graduating more medical students today than we have opportunities for them to do graduate medical education and train. And the reason for that is that all the graduate medical education is funded by the federal government. And it was increased a little bit in 2018, but every increase requires an act of Congress to appropriate more funding for those positions. And so the rate limiter on creating more doctors is not only time, but also funding and opportunities for them to do graduate medical education. And so I think that's a critical component of the equation to, if we really need to get more primary care physicians or get more providers out into the workforce, we have to have places to train them. We can't just put them through school and put them directly out into the workforce. It's a nuance, but it's a very critical point that I think is often overlooked. We've also had a lot of people who have left the healthcare workforce post-pandemic, as we mentioned earlier. A lot of the older physicians have struggled to adopt to the EHR, and they're more likely to leave medicine because of that, and because of the fact that really you can't do anything with a patient now without interfacing with the computer. And I think, some of the added workload as the clinical demand has grown, especially with diminished resources to address it. So I think that's a challenge, and there's different work priorities for younger generations, and I don't say that in a disparaging way, but historically, older physicians, that's all they did. That was their life, and they would occasionally see their family and do other stuff, and that's just not the way society is structured today. So I think all of those things are exacerbating the shortage issue. The things I would say that are on the positive side of that is that there's been an explosion of advanced practice providers who are filling a lot of these gaps, especially in primary care and other delivery systems. The rise of artificial intelligence, machine learning, we talked about data-driven protocols earlier. All of that is doing a lot of the knowledge work that physicians used to do. And, I think there's a lot of room for improvement in productivity. Physicians really should be working at top of license and not be functioning as gatekeepers and other things. And now a lot of specialties like physical therapy have gone to doctorate degrees so they can directly accept patients without going through primary care. So my hope is that the shortage is actually addressed through really other people doing a lot of the work that's currently done by physicians that is not top of scale, and some of the knowledge work being done by better data and machine learning. And I think the number of physicians that are going into non-clinical jobs is probably not a significant drain on the physician workforce.
So is there any limitation on the number of nurse practitioners and physician assistants? You say there's a significant rise in the numbers of those. That's not affected by Congress then?
They're not required to do the same graduate medical education that physicians are. And so there's not a federally funded training program that they have to go through. And so they are able to get out of school and go into practice. And they're, most of them have some level of physician supervision in most states. And in some states, they can practice independently. But there's not that choke point that exists for physicians.
Is there rivalry between these apps and the physicians? Are they encroaching more and more into that space, or is that good or bad? It seems like there's a shortage and things can be done differently. Can a physician assistant using artificial intelligence do a pretty good job in the ER?
Well, there's data to support that. I mean, I would say in terms of rivalry, I personally have not experienced that, but I'm sure this is a big country with a lot of people, and I'm sure that there's no doubt that that exists in some places. There was a lot of tension for years between CRNAs and anesthesiologists, and you could probably come up with another couple examples. So I'm sure that there are some instances of that occurring, but I work closely with advanced practice people in a lot of different capacities and have always found them to be a value add and an extension of our capacity to care for the patient. And I would say, too, that they generally care for the patient in different ways, especially nurse practitioners with their nursing background are really much better at doing some aspects of care than physicians, because physicians don't approach it from that same nursing perspective. And I would say, and in broad strokes, physicians tend to be a little less patient with the patient themselves. So I don't think that that's a hostile relationship, but I do think for sure that it is complementary, and there's a lot of work to be done. And if everybody's working at top of scale, it's probably done more efficiently.
Well, John, you've shared a lot of your observations and ideas for this non-clinical career transition. All that's been very, very good, but I don't want to miss out on your latest business adventure. You have touched into so many different business aspects, and this most recent one is extracorporeal membrane oxygenation, and I'll spell out the ECMO. So could you spend a little time, and we could do a whole podcast on this, I'm sure, but for the benefit of our audience, can you give us a brief business summary of the value, what it is and what it's creating?
Sure, I'd be happy to talk about ECMO. And I think this is a great example of, I feel like I can have a much bigger impact here than I could continuing to do individual operations. And so ECMO, as you alluded to, Bob, is essentially like long-term heart lung support. And, we think of dialysis as, a machine that replaces the kidney. This machine can temporarily, but for a long period of time, replace the function of the heart and lungs, while either we fix a problem with them, they recover, or we transplant them. And I first got exposed to this putting babies on ECMO in the 1990s, and it was really quite remarkable. And fast forward now, the technology and applications and techniques have evolved significantly, and ECMO is, applicable to a wide range of diagnoses for both adults and children. And when we institute this technology, we're using it in patients who usually are very, very sick and have very few, if any, options. Yet, despite that, all comers, we have over 70% survival in the United States. And if you look at specifically for cardiac arrest and shock, if you had a cardiac arrest out of the hospital and showed up at the hospital, your odds of leaving neurologically intact are less than 10%. And in randomized controlled studies where there's been great care, where they are now putting these patients on ECMO directly, the neurologically intact discharge is 40% or more in some instances. And so you're talking about massive improvement in survival. Same thing with respiratory disease. And, we saw a lot of use of it in COVID. You had some patients who were supported for over 100 days. And we're really seeing that it either allows the time for organs to heal, or It allows time for the physicians to figure out what the underlying problem is that's causing shock or arrest and then fix it. And so that is really remarkable. And what we're really driving to do at Innovative ECMO is expand access and awareness. So I think you could probably have 1 million cases of ECMO in the United States, but we're currently doing about 10 to 15,000.
Oh, wow.
So even if I'm totally wrong and it's not 1 million, if it's 500,000 or 750,000, we're really just scratching the surface. And so if you think about treating an additional 500,000 patients and 70% of them surviving, you're talking like almost 1,000 patients a day in the United States that could be alive if we had broad application of the technology. And so our goal is really to increase awareness, increase access, disseminate the knowledge, ramp up more hospitals so they're able to do this and train the people necessary so that it's widely available. That's really the goal of what we're doing. And an interesting, just like everything, there's always new opportunities. And the most recent one is now we're using the same technology to resuscitate and preserve organs for transplantation through what's called normothermic regional perfusion. So a lot of times when patients die, they don't have the opportunity to donate, but if we're able to preserve and protect and revive some of these organs, we are dramatically increasing the donor pool for especially abdominal organs. So, I mean, for me, I feel like I'm probably touching more patients every week doing that than I was in 20 plus years of operating. So it's a great example of, I was very excited about going and doing this because I really felt like I could have a bigger impact.
There's a lot of training and education involved with that. And it's amazing how you can develop a market from a business perspective. Well, John, I would be remiss not to mention that you are a graduate of the University of Texas, Dallas, where you earned your MBA in the Alliance for Physician Leadership program. And I want you to know that you're always welcome to come back here and share your insights. So I want to thank you again for revisiting. Let's not make it 5 years again before we have a chance to do another podcast with you, okay?
Yeah, it's always a pleasure. The program there was fantastic. You and Dr. McCracken were fantastic. I've referred several people there. So that was a great experience. I'd love to come back, and I'd love to do the podcast again anytime.
Very good. Thank you, John.
Thank you.
Thanks for listening to the Business of Healthcare podcast. To learn more about the Center for Healthcare Leadership and Management, go to jindal.utdallas.edu/healthcare.